Thank you again, Dr. Rodriguez, for coming today. So just by a quick introduction to Dr. Rodriguez, he's an assistant professor of computer science at the University of Michigan, Ann Arbor. His research spans the intersection of machine learning, time series, and scientific modeling, with a focus on applications in public health and community resilience. His work has garnered recognition through publications at premier AI conferences and multiple awards, including the 2024 ACM SIG KDD Dissertation Award runner-up, the 2024 Outstanding Dissertation Award from the College of Computing at Georgia Tech, and a Best Paper Award. His homepage is alrodri.engine.umich.edu. And thank you very much, Dr. Rodriguez. Up to you now.
Thank you very much. Thank you for the invitation. It's a pleasure being here and sharing our work. If you have any questions, please feel free to interrupt me, or also if somebody can monitor the chat, maybe I might not be able to look at it, but as soon as I see your question, I will be able to address it. And if it is a question for longer discussion, we can take it at the end. I'm hoping to have a conversation with you on the methods that we have developed and how I think that some of these techniques can be complementary to what you have been doing, and also we can probably in the future even contribute to this space together with your expertise as well. So I'm going from a computer science department, so we work on machine learning, AI techniques, and we are trying to make really the effort of bridging with public health, with epidemiology. We have been doing this for multiple angles, from purely data-driven angle, just using deep learning methods for public health prediction. And also, more recently, we have been exploring how we can connect with knowledge in epidemiology based on differential equations, simulations. I will be discussing about that today. So I'm hoping that after this talk, you have a better understanding of what has been done in this space, at least in my group, and also what are some open challenges that remain to be addressed. So, okay, so let me, I'm sure that you're very familiar with how epidemics spread the populations. You may have seen these maps during the COVID-19 pandemic, and each of these circles will be representing number of cases or number of hospitalizations in one locality. And what I have been caring about is looking over time how these trajectories evolve. And these are, for example, one trajectories of epidemic curves, also of community confirmed cases for multiple countries. So these are going to be giving us an understanding of what is happening currently and also a potential outlook to the future. So you know that it is a very important problem in the US. It is we have these numbers for COVID-19, thousands of hospitalizations, thousands of deaths, and they are same for influenza. And even though this may be looking like maybe this is a collection of multiple years of hospitalization and deaths, this happened only during 30 days in the previous winter, 2023-24 winter. One single month we had these numbers. So clearly this is a significant problem for our society. And there are, as you know, there are multiple agencies that are helping us to combat spread of diseases around the world, like the World Health Organization, that the CDC, and I am in Michigan, so we work with the Michigan Department of Health and Human Services also as well. And the task decisions that or the information that they will collect, and they will be they want to use this information for situational awareness, for forecasting, source detection, missing infections, in order to make decisions like resource allocation, individual risk assessment for people, and even development of therapeutics. In my work, we have been mostly focusing on situational awareness and forecasting. I can speak also from other, for the broader community on data science or machine learning for public health. People have been addressing also problems in source detection, in missing infections. I will be talking a little bit more about that community later in my talk and how we are helping to grow that community. But specifically in my work, we have been addressing the first two. And if you're not very familiar with these two, let me give you an example. This is a real world example with data from the state of Oklahoma. You can see in the x-axis we have time, and in the y-axis we have mortality, COVID mortality in this case. And what we are the challenge or the task that we have to do in real time is to predict what's going to be the future of this epidemic curve. And you may be thinking that there will be a few outcomes. It may either go down, stay still, or may go up. And indeed, what happened in reality is the red curve here, you can see there, which is it went down slightly and then it went up, as you can see, considerably. Predicting this in real time is super challenging. It's really, really challenging. And the CDC, we have been partnering and working with the CDC and other uh, teams around the United States in order to make these predictions in real time. Uh, and it is an impossible challenge if you don't look into other possible indicators or indicators that they can give you some information on what is happening on the ground. For example, if you are predicting here mortality, clearly you have to look at the number of infections, but you know the number of infections, there are some issues, for example, in the reporting, delays, also corrections. So we have to account for those issues as well. We cannot just blindly use these data sets, but they are useful, definitely. We also want to look into the contact patterns in populations. We want to look into people with experiencing symptoms, and these data sets may come from traditional sources, but however, they may have some problems like delays in reporting, also selection bias. And there are other more recent data sets that are available or were available during the pandemic, and they are now currently available in different forms. From coming from Facebook, for example, they were collecting surveys from people experiencing symptoms. Google, similarly, but with search every time that you search for on Google, and you may be searching for some symptom about any disease, they will be collecting it and then making it publicly available for researchers. After, of course, they aggregate and also they do some privacy preserving procedures in order to release the data safely. And then there are multiple aspects of multiple companies that they will provide in these data sets. And these data sets, indeed, multiple papers and including our work, have shown that they have greater sensitivity, granularity, and timeliness than traditional sources in public health. In some cases, not I'm saying, but in general, we have found this conclusion, and also greater availability thanks to the interest in public health. So the question is, how can we leverage these data sets in a meaningful way, and also, and more importantly, inform decision making with this? So the vision of my work has been on creating these prediction pipelines that connect with decisions. So data sets that I was referring to, we can have them in the left. We want to make predictions about the future. And also we want ultimately to inform decision making. So the question, a motivating question for my work has been how we can connect, or how can we better connect data to public health decisions to predictive modeling. And the approach specifically that my work and my group takes is building deep sequential models and also scientific machine learning in order to bridge knowledge in epidemiology with the data-driven expressibility of AI. So having said that, I will now proceed to emphasize some of the technical challenges that we face by realizing this vision. One of the challenges was how we can first leverage this heterogeneous multimodal data that is coming from multiple sources, heterogeneous in the sense of heterogeneous sources. The dispersed sources, each of them will have a different data collection procedure, the different noise levels. How we can handle this in a meaningful way or in a principled way is a challenge in the first place. But one initial challenge that we had in responding to real-world epidemics was that the data is scarce. If you compare with other AI or deep learning applications, if you compare with large language models, this is even much larger number of observations. But even with maybe older old models or older data sets, like say for 10, we have thousands of images for flu or COVID-19. If we want to respond immediately when it started, we have much less observations. So how can we handle this problem? It is something that it is non-trivial when we are dealing with machine learning models. Another aspect is that things change. There are some distribution, what we call in machine learning distribution shifts, but it is an example how we can understand it. For example, before the vaccine, if we had seen more people being in contact, mobility will be increasing, then we will expect that there will be more cases, more hospitalizations. But after the vaccine, this will be more nuanced. There will be a more complicated relationship and more factors to consider. And this, or you can also think of a new variant or a new behavior of people, and that is going to be incorporating complexity, and machine learning may fail in those cases. So that is one of the challenges that we wanted to address also. A second set of challenges are issues arising from real-time settings. Here, we consider that the data that we have is not carefully cleaned. There are some data quality issues. Just to give you an example of something that we studied extensively, this is an example with data revisions. And you can think of the data being released by the CDC as the one that you can see there in green, the January 1st data that the CDC released on that day. And then if you had that data, a reasonable model would make some predictions like the ones that you can see in the blue. The blue predictions are the ones that the model made. However, it happens that 2 weeks after, the CDC says that actually they receive more data from hospitals that they didn't count before. And now the data in the green one that it was released initially on January 1st, in January 15, now has been revised to a new value. And you can see that now it looks very different to the initial value. So now your predictions in January 1st were misled, or your model was misled because they didn't account of this data revision problem. And if you continue on time, in January 29th, the CDC will release this data, and you can see that the data over time is also we have more observations, but even within one time stamp, we have also multiple versions of the data, multiple values. And later in April 15, it will be almost revised. So how can we account for this problem? But first, in order to first account for this problem, we wanted to characterize it mathematically, and then also analyze the data or what was happening out there. So what we did is something like look into one single observation week. We call it observation week, let's say a 52. And then we are going to be looking into that column of that set of values that are marked in red. And we can create what we call a revision sequence. A revision sequence 0 is going to be when, as soon as it was released, all the way until infinity, because today even the signal is going to be, it may not have changes anymore, but still it's going to be available in the value for that signal. So the revision sequence is useful because we can analyze some properties of this revision sequence. For example, what is the revision error? What is the initial versus the final value? What is the relative error between these two? And also how many weeks it takes to stabilize. What we did is to analyze 30,000 revision sequences from multiple sources, public health sources, and also even digital sources like Google, Facebook sources. And we found that half of the signals had more than 30% of this revision error. And on average, it took like 4 weeks to stabilize. And one also interesting finding was that the revision dynamics were not uniform. There were some cases where we had early decline, other cases we had early increase, late rise, and mid decrease. These are 4 examples where we found actually kind of clusters of these time series. And by considering this, we can perhaps help to revise it and also to account for this problem in our edit forecasting approach that we are going to be using for epidemic predictions. So this is a second challenge that I want to emphasize, the issues related to the fact that we are dealing with a real-time setting in which there are multiple issues across the entire data collection pipeline. And a third issue that we are looking into is how we can bridge data and knowledge in epidemiology. My work is advocating for the use of these causal mechanistic discoveries discovered in the scientific knowledge in epidemiology. One of the goals is improve trustworthiness, but we also want to see if we can also answer some qualitative questions and also some what-if counterfactuals with the help of these mechanistic models. And if you open this book, you will find that what is known as mechanistic epidemiological models. And broadly speaking, we can think of two classes of models. Ones that are based on ordinary differential equations, ODEs. Here in this ODE that we have here is called the SIR model. And this SIR model, S represents the people that are susceptible or healthy, that they can be, they are prone to be infected, but they haven't been infected. I is the infectious people, the people that can infect. And R are the people that have already gone through the disease and recovered from that. And you can see that there are some parameters, and there are also some differential equations that will govern how many people is moving from one compartment to the other compartment. And if we have some initial conditions and perhaps also some data about infections, we can calibrate this model, and we can have a solution for this ODE. And my work, we have used something similar to the SIR model. We have used a more sophisticated mechanistic ODE model. And the one question here is how we can use this model and complement it with machine learning and see if we can get the best of both worlds. And similarly, or maybe another group of mechanistic epidemiological models are the agent-based models. Agent-based models are simulations where we have people interacting in a computational world, and each of these people are going to be interacting in different settings with different kind of people. Some of them are going to be interacting in the workplace, others in the household, and others in the school. Maybe the kids are going to be in the school mostly. And these are essentially contact networks. Probably in computer science, we usually call them contact networks. So we will have a multi-layer contact network, and we will have simulations of the people across these dynamics contact networks. And again, the question is how we can leverage the usefulness of the agent-based models that can be very granular, can help us to understand what if predictions, understand policy development with machine learning, and how these two can be supporting each other. So exploring these questions are part of my work. So the contributions in general of my work have been on developing new expressive methods for public health. We wanted to respond to disease outbreak. We wanted to make them useful. I shared with you that we have been working with the CDC. I will be referring about that in a moment. And also we wanted to incorporate this mechanistic or expert guided priors into a learning process with machine learning modules, deep learning modules. And then, as I said before, bring the best of both worlds. And we have shown how this enables us to push the boundaries in what is short-term and long-term predictions in epidemics, how we can do also outbreak detection, trend correlation, and what if analysis. And we also have been deploying these systems. We have been participating in the COVID-19 forecast hub. We were among our deep learning models were among the best models in this COVID forecast hub. We also participating in some data science challenges, and we obtained the first and second place in these ones. So with that, now I will move to a overview of the solutions and some highlights of the results. Before that, I wanted to maybe stop here and ask or maybe stop for any questions that you may have. If not, I can continue also. Okay, I am hearing no questions so far. So let me now talk about the solutions that we develop for each of these three challenges. So I will be talking briefly about the first two, and then spending more time in the third challenge, which I am really excited to share with you. I think there might be more common points there than in the other two. So regarding to the first challenge of how we can address epidemics in the real world and leverage the multimodal heterogeneous data that we have. We created a operational framework for deep learning methods. We call it Deep COVID. This was in 2020, 21, and essentially we have three modules here where we are processing first the data. We are addressing some challenges with the data, like delays in reporting. We have to also normalize some temporal granularities and consider the spatial aggregations. There were disparate spatial aggregations, temporal aggregations, imputations that we have to do in order to have the data as clean as possible for the prediction part. In the prediction part, we have a neural network-based model where we were using, we had changed it as considerably since the very beginning, but essentially what we were doing is obtaining probabilistic predictions. A probabilistic prediction means that for every single prediction that you do in the future, you will have a probability distribution as well. I will refer to that and how to do that, how we do that now, in current days, in current time, in a bit. And the last part of this framework is explainability, where we want to understand what are the main drivers of the predictions. Maybe there are some data sets that are driving the predictions that are very influential, and understand the robustness of them, visualize them if there are any problems. So all these things are being done in this module we have there. And I just want to show you some highlights of the results back then. It was a success that we were able to anticipate some trend changes. As I mentioned before, it is very challenging to make the predictions in real time. And we were very glad to see that the machine learning model was picking up some of the trends and actually making a sometimes very accurate predictions about what will be the trend change. This is very challenging, but also useful kind of piece of information in order to make preparations for public health officials and downstream decisions that are down the road. We also, machine learning models can capture, if we want, we can capture some finer grain patterns. These patterns, for example, about the reporting, sometimes the reporting is less during the weekends than during the weekdays. So these patterns, or even though they are not super important for decision making, but they can be also useful for showing the experts something similar to what they would expect or they have seen in the data. So that could relate better with them uh, or be more in synchrony with what they're understanding. So that is something that if we want to have, machine learning models can help us to obtain this. If you would think about a mechanistic model, it will be mostly predicting just one single line, more on the trend side rather than these fine-grained patterns. We also compared against the COVID hub ensemble, which is the combination of all the models in the COVID forecasting hub. And it was very competitive, our model in several cases. In some states, our model had also issues. Most of the times were states where we have less population, possibly because the data when the states will have smaller states with a smaller population, we have some data that is more noisy or maybe more spiky. So, for example, if you have the average can be that is 10 people dying per day or per week, and then if it moves to 20, then it's a huge increase. And maybe if it moves to 15, so it's more significant. In if we go to California, 10 people or 20 people is going to be a small is a variation in there. So in those cases, our model was not doing that well, and it still remains a challenge even for these machine learning models. And as far as I know, also mechanistic models have challenges also with those states. But in other states, we will where we have more data, we have more statistical sample, then our models will do much better and comparable to the COVID-19 COVID hub ensemble. And also, finally, also provide some explanations about, for example, if what is the main driver, as I mentioned. In this case, it was a mobility. We found that it was among the main drivers for this specific case. We, in general, back then, we started with some simple models because the data was also limited. But little by little, we were making it more sophisticated. And addressing the first challenge that I mentioned earlier, regarding to how we can leverage multimodal data. We were incorporating some constraints regarding to acknowledging that we were dealing with a spatiotemporal propagation process. That means that regions that are connected to other regions are going to be experiencing similar epidemic curves or epidemic dynamics. So incorporating these constraints into a learning process can be helpful for overcoming also some of the limitations in the data. We also explore how we can handle or how we can do principal multimodal and certain quantification. As I mentioned before, every source is going to have different data collection procedures, different errors, and different noise levels. So we may have to encode each of them in a separate way, and then combine these together, combine also these noise levels in a meaningful way. Deep learning models can help you to do that, to facilitate that by by creating architectures that will be modeling each of them separately and then combining them with a learning process. So there will be a process that will be learning how to combine these multiple modalities. And if another aspect what we studied is how we can look into the multiple hierarchies in the data. We have, in this case, state level predictions. We have also national level predictions. Even we can go even beyond and then look into county level predictions. And each of them, you may use a machine learning model for predicting at each level, but there has to be some coherency between the hierarchies. So if we have these constraints on coherency, we can actually further improve this forecast and improve not only the performance, but also the trustworthiness of these predictions. If they are not connected to each other, then if a decision maker wants to look into the big picture, the overall picture, they will not be making sense. But if we put them together into the same learning process, that will help us to make it more coherent and therefore more connected to what an expert will be looking to see in a prediction. And regarding to the second challenge, as I mentioned, that we're handling multiple data quality issues. Some of them were related to missing values and delays in reporting. And others, as I mentioned before, data revisions, how we can correct these data revisions with machine learning modeling. This was just one example of what we did. We were trying to understand how these multiple signals connect in a latent space. A latent space means that we are going to be projecting the signal, the time series into another space where we are going to be learning how similar they are going to be to each other. And then once we learn how similar they are to each other, then we can leverage this similarity via a graph. So we create a graph that is going to tell us how similar they are. And then we can build a neural network architecture that is going to take advantage of this similarity and also the temporal dependencies inside each of these groups of signals. And what we work on is to try to use these representations or this information of the patterns of data revisions in order to improve our forecasting models. In case we were using our forecasting model like the one that you presented, the one called deep COVID, but we also tested this in other models, even mechanistic models. You can see there that if deep COVID, it will be the orange one, but there will be other methods, like, for example, even the ensemble method or the UMass MB, which will be a mechanistic model with Bayesian optimization. So these are models that we can take the outputs, take the predictions, and then correct them based on these data revision patterns. And here in this plot, in number 4, we are putting how much each of these models was improved, or the performance of each model was improved, thanks to this incorporation of the data revision dynamics. So this is one example of what we did during the pandemic. And another more recent example, more recent work that we have been doing in my group in uncertainty quantification is how we can adapt this distribution, adapt these intervals, the prediction intervals that we have to distribution shifts. We have an idea based on the control system. So you can think of this as we want to achieve certain coverage. Coverage means that if you're saying that 50% of the time the ground truth data is going to be falling within your prediction intervals, then it should be 50%. But sometimes in reality, we see that actually goes to 20%, 0%. And then that is going to be hard in trustworthiness of these predictions. So in order to do this well, we are taking advantage of what is called conformal prediction. Conformal prediction works for any method out there. So if I were mechanistic method or machine learning method, it can work for any. And it's going to be learning how to adapt these prediction intervals so that then we can always maintain the desired prediction, the desired level of confidence, which in this case, in the example that I gave, will be 50%. So we developed a framework in order to do that, and we tested it in COVID-19 and influenza, following the CDC requirements. These are some plots of the performance of this model, and here in this case, a lower performance or lower of these metrics will be better performance. And you can see that in COVID and flu, here in calibration score, which is a quantification metric, our method is better than these other methods in conformal predictions. There are multiple methods in conformal predictions, and we wanted to showcase the usefulness in that aspect, and also maintains the probabilistic accuracy, which is measured by the weighted interval score. This is another metric that the CDC uses in order to rank the models. So we also want to be doing well in weighted interval score, but significantly better in calibration score. So these are some results that I wanted to emphasize, but I think I wanted to specifically mention about this one in the right, that these methods that percentage quantification can be adapted to multiple methods that might be out there. Some of them are machine learning, but you can have your favorite model here. Let's say that you have a mechanistic, ODE-based model, an agent-based model. So you can also use these methods in order to assess the static quantification and also properly adapt it to distribution shifts, to changes in the dynamics of the epidemic. So these are two examples of what we have done in this space. As I mentioned, we have been working with the CDC in COVID and influenza, included in the CDC official ensemble. And thanks to this visibility, it has been used by decision makers on multiple levels. And also, it has been the only deep learning model in the top five ranking, but in the CDC Forecast Hub. So this is what we have done in this space regarding to the first and second challenge. And now let me move to the third challenge, which is bridge data, AI, and knowledge in epidemiology. But before going there, is there any questions so far? Okay, hearing no questions, let me now talk about the specific method solutions that we had for here. Before going to the methods, I want to explain you two specific hypotheses of how we think that each of these modeling paradigms, we think of this about modeling paradigms complement each other. So the first example that we have here is addressing the question of how can mechanistic models help AI. So here is a real world example. Here, Delta wave. This was in 2020, late 2020, and then we have the Omicron wave. The case here was that in the Delta wave, we have seen some peaks up to the 100,000 cases per week. But in Omicron wave, we saw something much significantly higher than what we have seen before in the Delta wave. It was 350,000 cases per week, much more contagious than the previous strains of COVID. So what could we do in here? The task again is just forecast the future of epidemic. And if we had a machine learning model in the present time, you can see the line August 2021, a machine learning model, we saw our machine learning model doing is because of the number of cases, and cases here is an input to the neural network, number of cases is so large, then the machine learning model will give you just such a large prediction, just to all up to the roof, right? And you can see that even we cannot even see what will be the entire prediction for the machine learning model. It will be outside of this scale of these values. So what is happening here? First of all, machine learning model that hasn't seen data similar to this. There is a significant shift in the dynamics, and machine learning model doesn't have any constraint or any guidance that there will be some that you cannot just make a prediction like that. There will be some saturation of people, right? There will be some you cannot infect forever. There will be certain saturation, and that saturation will be coming actually, or we can come from a mechanistic model. So you can see that in the short term, and that is what actually we have been submitting in our predictions. In the short term, to the CDC, they usually care about 1 to 4 weeks, and that's reasonably okay. It's not really horrible, the predictions, but if you look into the long term, this is completely bad. This is ridiculous, even the predictions. So what we are trying to understand is how we can predict, how we can improve these long-term predictions. And one idea that we had is perhaps we can look into this model, this SIR model, and this which actually help us to understand these long-term dynamics, and then we can extract these long-term dynamics from these models and bring them to the machine learning model. And of course, we know that this SIR model is going to be a bit simplistic, and sometimes it's not going to give us good predictions. The machine learning model, indeed, many cases is more accurate. However, it can give us some guidance about the long-term dynamics, and that is one of the useful things or useful cases for connecting these two paradigms. So now let me now switch around, and now let's think about the mechanistic model, how it can it be helped with the AI systems. And if you have worked with mechanistic models, either ODEs or simulations, it is non-trivial to add data sources. You will have to work out the causal mechanisms of how this data source is going to be incorporated into your pipeline or into your specific model. So machine learning model, as you may remember, it is a way to facilitate this incorporation. So it can perhaps help there. And a second aspect of how or some difficulties with mechanistic models is that if we have a model where we are dealing with multiple moving pieces, or it's a large scale model, it's going to be complicated and cost prohibitive to calibrate. And indeed, if you have a mechanistic model like an ODE, you change a little bit beta, it's going to have a very different outcome, different epidemic curve. So they are very insensible and very challenging to calibrate. And we have been exploring how these machine learning models can help you to this calibration of the agent-based models or the ODE-based models. So the two specific frameworks that I would like to present is the first idea is how we can incorporate the dynamics of an ODE into a neural network, how we can make it the neural network to be more cognizant of these dynamics. And the second idea is how we can incorporate neural networks into the calibration of a mechanistic model. In our specific case, we explored an agent-based model, which we are reformulating it as a differentiable function, or differentiable simulator, also known as differentiable simulator, and then we can connect it with a neural network and do some gradient-based optimization. The difference with our proposal with other proposals in the past has been that we are really trying to bridge mechanistic models with machine learning models in an end-to-end learning framework. What does this mean? Traditionally, what we will do is to go from data to parameters. So let's say we have multiple data sources like Facebook, Google. We will have one machine learning model or linear regression model that will be making predictions for parameters. And then after doing that, then you will have another one that is going to be making you another pipeline, which is going to be with the mechanistic model. You have the parameters, mechanistic model, and then you give you some forecast, and then you will be calibrating this part. So it will be a disjoint calibration. Instead of that, what we want to do is to facilitate this process in a joint optimization, where we have data directly to epidemic forecast, and inside the pipeline, we will have the neural and mechanistic components working together in a closer manner. And this also leads us to some advantages. For example, now we can bring ideas in gradient-based optimization. And gradient-based optimization in practice works better in multiple cases than gradient-free optimization. And we can take advantage also of some packages and computer architectures that hasn't been much explored in public health. For example, packages like PyTorch or JAX, and also we can use GPUs because we can parallelize a lot of these processes. We are going to be talking a little bit about that as well. Okay, so any questions so far before I talk about the two solutions?
I think we have a question in the
Oh
chat
yeah,
actually from Florent. He's asking, what kind of ODEs are you using for modeling?
yes. So the ODEs I'm using are similar to the SIR model. So we had it here, but actually I will, so this one is similar to the SIR model, but specifically in my work, we have been using the SEIRM model, which is more appropriate for COVID-19 because it has a period of latency. So that is a specific ODE that we have used. And there is another question. Okay, thank you. Okay, perfect. Thank you, Fiorent. Perfect. So let me now go to these two solutions that I just mentioned. Um, the problem here is AI needs mechanistic models, and the idea is we want to incorporate the dynamics from an ODE-based model into a neural network, essentially teaching neural networks some of the basics of epidemiology. And here what we have rely on or building on top of the body of work in physics-informed machine learning, specifically with physics-informed neural networks. I will not go. I don't want to really go too much technical into this because maybe not everybody is familiar with physics-informed neural networks, but just a high-level idea. In physics-informed neural networks, we will have usually we will deal with the problem of given a given an ODE and given some data, we want to calibrate this ODE. Calibrate means find the parameters and also solve the ODE in general will be also solved for the entire time or the entire domain. We want to know what is the values of all the compartments. In this case, we have the SEARM model. So we want all the compartments, what are the values for them over time. The issue with these physics-informed neural networks is that they don't have a mechanism to incorporate the data sets that we talk about, which are the Google dataset, the Facebook dataset, and so on. And in addition to that, in general, the physics-informed neural networks are not going to be useful for making predictions about the future. You will be able to have a good understand or maybe good fitting to the training data. Training data, you can say, the physics-informed neural network has able to fit well my training data, and it follows the differential equations that I imposed. However, in the future, if you want to extrapolate, this is not going to be guaranteed. So what we are doing is to using the ideas of physics-informed neural networks in order to have a neural network that can or take advantage of these differential equations, follow these differential equations when it is useful to follow, but also be able to extrapolate, be able to connect the data from Google or even public health sources to future predictions. So we have to do some extra things, and I will invite you to look into the paper. Actually, this is not archive. It should be AAAI 2023. I'm sorry, I forgot to change this citation in the top, but it's a paper that we have this called epidemiologically informed neural networks. And the idea is what I said, right? And we have to incorporate, do some technical innovations in order to enable that part. And in addition to that, we had to incorporate some epidemiological constraints, understanding that these dynamics of the epidemics doesn't happen. There are some relationships that they have to follow. For example, S compartment, it has to be always monotonically decreasing. It is simple ODE, not always, but in the simple ODE that we have here, it's going to be monotonically decreasing. And for R and M, it's going to be monotonically increasing. So then we can incorporate these constraints and make it easier for the neural network to learn these complicated dynamics. Otherwise, it is really challenging. And by doing this and doing these innovations that I mentioned, what we wanted to achieve is to have the best of both worlds. Essentially, and this is a picture that I wanted to showcase to show you to showcase what is the advantage of each of these methods. So the machine learning methods, which is in yellow, they will have low error usually, but they will have a very low Pearson correlation. Correlation is essentially correlation with real epidemic trends. So they will be not correlated, and these are a Pearson correlation will has short and long-term predictions in account. In contrast, mechanistic ODE model is going to have a large error. However, it's going to be very useful for the correlation. The correlation is well correlated with the actual epidemic trends. We wanted to have something that can take advantage of both of these strengths of the models. So in our method, which is the red one, we have that we can achieve actually also or maintain this short-term and long-term error as low as possible, and increase our Pearson correlation, increase this correlation with actual epidemic trends. So this is what I wanted to showcase or on the best of both worlds, right? Something that we can actually achieve if we can properly combine these two methods and make them work together or use them appropriately. And this is all the comparison with the CDC baseline that people, and also our deep COVID method that I mentioned before. These are some results that, and we also have some flu results also in our paper, if you are interested in looking at them. And now let me move to the second idea that I wanted to, this is the final idea that I have in my presentation, which is how we can calibrate an agent-based model with a neural network. And here I have how traditionally we will do, and with a traditional agent-based model, we will have some parameters theta t and theta p, which is theta transmission, theta parameters for transmission, and parameters for progression of disease. And we will have a simulator that after running it for multiple days, we can have these epidemic curves. And usually what we want to achieve is a change or do some changes in the parameters so that then we can have the epidemic curves to be closer to the real world epidemic curves. So this is called also an inverse problem, and it's challenging because we have multiple moving pieces, also parameter sensitivity is high. And another challenging part is how we can incorporate the data sources that I referred to before. So we created one framework in order to enable this too. We first reformulate the agent-based model as a fully differentiable process. I will explain in a moment how we do this. And then what we have is a neural network that is going to be taking multiple data sets, processing them, and converting them to predictions of the parameters of the agent-based model. And then the agent-based model, we can run it for multiple days and then get some results from them. We can aggregate about, we are in the agent-based model, we are simulating at the individual level. You can think of this as a 1 million people in a city. We are simulating every single people and then aggregating for every day how many people are in each compartment. And then we have some ground truth data from the CDC about the mortality. So we have only the mortality compartment or the mortality people. And then we can have an error. We can calculate an error and then we call it the machine learning a loss function. And then we can do a propagation to the parameters of the neural network. So now how we do this? The key idea here is reformulating the agent-based model as a differentiable simulator. So what we have done is to take advantage of some existing simulators and reformulating them into differentiable process. So just to give you one example, I have here one slide. We take advantage of some invariances in the disease transmission dynamics in order to convert. What we're saying is essentially that within one day, if you are meeting the people in certain order, Doesn't matter really the order. The outcome will be the same. So what you can do is to have a contact network like this, and you will have a function that is going to be going across all the neighbors of every node. And this function is going to be given by domain experts. So there will be this function is going to be giving you the probability of a person to be infected. So what we did is to go to the literature and see what are the some possible parametrizations for this function. So we found this specific parameterization for this function, which were giving us the probability for given two interactions between two people, the probability of them being infected. So if you are familiar with graph neural networks, this is essentially a graph neural network, but instead of having a black box model, you have now a function that is given by domain experts. And now you have something well defined, but we can now use also graph neural networks. And if you're familiar with graph neural networks, they are already optimized to be parallelizable. So we can parallelize multiple of these computations. And if we have a 1 million people here, we can do it much quicker than if we are doing it one by one in a for loop. And what we have to do is also reformulate some of the disease dynamics, disease progression dynamics. We are modeling as tensors. So you can think of a tensor of 1 million people, and then we have to update this tensor on every iteration. And we also have some stochastic processes. As I said, we are going to be getting a probability of infection. So in order to make people to move from one compartment to the other, we have to sample from that probability. And this sample, it can be non-differentiable. So we have to approximate it in order to make it differentiable. And I remember the idea of making differentiable is because we want to connect it with neural networks. So if we have it differentiable, number two differentiable, then we can do this process with power propagation.
We have a question actually, Dr. Rodriguez.
Yes.
Again from Florent. He asks, what are the required computing resources for running these simulations?
Yeah, that's an excellent question. So the required computer resources are going to be very small depending on the it's going to be usually as much smaller than normal AMS modeling. So for example, for one county that had 1 million people, for simulating it for 40 days, I could use it in my laptop. My laptop was uh, my old laptop was how many 8 GB of RAM, and I didn't have GPU at all. So even my laptop I could run it. When I was running more experiments, I actually will rely on some server with GPUs. But just to give you an example, just a simple laptop with 8 GB of RAM, it could handle a 1 million people simulation and train it and train it. Essentially, the simulation, the forward simulation, which is from 1 to 3, this is very inexpensive. But in doing number 4, then you have to save a lot of the gradients. You have to save a lot of the intermediate results, and that can be considerably expensive with respect to memory. But the other part is really quick because everything is in tensor. In tensor, there are tensor operations. They are very quick to do. Actually, we have one plot, also one figure here. Uh, so this is another AMS model that is from the UK, and what we did is to take it and convert it to to a differentiable AMS model, and it took with the normal calibration. They took with Gaussian processes took about 100,000 CPU hours, and with our approach, it took about 12 CPU hours in order to train this or to calibrate this model. So these are examples that you can find in the paper. This paper it has been published in a machine learning conference. And it's called AMAS 2023. Now, to show you some results, also some additional results that we have, we compared this approach with other calibration methods for AMS models, and we also compare with some variations of our model. Our model results are in the ones in the red. They have lower error than the other calibration approaches in COVID-19 and influenza. And for COVID-19 and influenza, we had some different disease progression models. So for COVID-19, we have the SCIRM, but for influenza, we have the SIRS model. And we can also do what if analysis. In this data, where we are doing is a more data-driven calibration. And we found that having a better calibration can help you to also to rethink some policies when you are evaluating them. And in this case, we evaluated if whether we should or not delay the second dose of the COVID-19 vaccine. So with that, I want to briefly talk about some conclusions and future work. I show you already these expressive AI methods. I went through multiple of these. I stopped in a few of them where we were connecting with the mechanistic models. In addition to these multiple capabilities and methodological advances that we did, we have also been trying to build a community around machine learning, data, and public health. We have a survey in native machine intelligence about the multiple methods in epidemic forecasting, from deep learning, traditional machine learning models, and also these hybrid models where connect mechanistic and machine learning components. We also organize tutorials at top AI conferences and also workshops. I invite you, if you're interested in knowing more about this, to invite you to explore this. Next time, hopefully, it's going to be in Canada, in Toronto. We're going to be having Epidemic. Every year we have it in KDD. So hopefully this year also we're going to be having it there. I want to mention that this is one example of the multiple AI problems, AI computer science problems that we can see at intersection of epidemiology, public health, and AI. We have problems on certain quantification, explainability. If we want to use individual data, we have also private ML problems, HCI in order to provide explanations or visualizations to experts. There are multiple things that we can do here in addition to causal inference, computational social science in order to incorporate behavior into these systems, and HPC to run large-scale simulations like the one that we did in my work. So I hope that I show you that the accessibility of AI can be useful in public health. There are multiple positive results in that space. It can also leverage some interesting and new problems in AI, like the ones that I mentioned here in this presentation, where correct data quality problems or knowledge-guided machine learning algorithms, differentiable simulators. There are some. This is one as a subset of the interesting problems that public health can motivate, and definitely exciting avenues to collaborate. I want to acknowledge the help of support of collaborators across this work, and thank you, and look forward to your questions.
Great. Thank you very much, Dr. Rodriguez. That was a really interesting talk. So I think we only have a few minutes before we have to end the seminar. So I will jump straight into the questions. We have one here from Vivian, and she asks if the frequency of predictions changes the performance of the model. So would the model have significant differences in prediction performance when you try to predict the number of COVID cases by week compared to by day or by month? And if yes, how would you usually decide on this prediction frequency?
Yeah, that's an excellent question. We haven't found significant differences in performance, and usually we have been following what the CDC prefers to do, which is the weak predictions, and that has been our main evaluation framework. But in general, we haven't found any significant differences. That's a good question. Thank you.
Perfect. Seems okay, great. We have another question here from Tara, which I can read out. Obviously, anyone feel free to also just speak up. But Tara's question is, I'm curious about the sensitivity of the integrated mechanistic model slash neural network approach. If the model is misspecified, how sensitive is the model to that? If the data differs, can the model correct? Similarly, how can the last two ideas you shared, ML-informed mechanistic model and model-informed ML, be integrated?
Yes, that's an excellent point. So if the model is misspecified, we are we have you can think of this mechanistic model to be helping us to regularize the machine learning model. So if you're familiar with regularization is going to be a technique which is going to be the machine learning model will be departuring from its initial solution, from the data-driven solution, only if the mechanistic model is actually helping it to make better solutions. So in that case, you are controlling the effect of the mechanistic model. If the mechanistic model is misspecified or doesn't work well for that regime, then it will be paying less attention to that mechanistic model. And there are other parts on the epidemic curve, or for example, or regimes in general, that where the mechanistic model can be useful, more useful, and then the machine learning model should automatically detect that when it has to use it.